Assalamu alaikum. Welcome all to Easy Human Anatomy channel. In this video, I discuss clinical anatomy of the thyroid gland. Why thyroid gland move up and down during deglutition or swelling? You see, this is a enlargement of the thyroid gland and it's moved during deglutition. The pretracheal fascia is the false fascia of the thyroid gland and it's connected to the oblique line of the thyroid cartilage and the body of the hyoid bone. And the medial surface of the thyroid lobe is thickened to form the suspensory ligament of the berry, which attaches the thyroid lobe to the cricoid cartilage. As a result, when thyroid move up and down during deglutition, the larynx is raised along with the pharynx by the contraction of the longitudinal muscles of the pharynx that are attached on the posterior border of the thyroid cartilage. Thyroid gland also move, and this helps in distinguish the thyroid swelling from the other swelling in the neck. Superior thyroid artery is ligated close to the thyroid gland, and inferior thyroid artery is ligated away from the thyroid gland. Why? This is the superior thyroid artery. You see, it lies close to the external laryngeal nerve at its proximal part, and they became diverse and superior thyroid artery became superficial and external laryngeal nerve became deep. Therefore, during thyroidectomy, the superior thyroid artery should be ligated close to the apex of the thyroid gland to avoid injury the external laryngeal nerve. Inferior thyroid artery is very close to the recurrent laryngeal nerve near the base and lower pole, you see. Therefore, during thyroidectomy, it should be ligated away from the inferior pole of the thyroid gland to avoid injury to the recurrent laryngeal nerve. In partial thyroidectomy, which part of the thyroid gland is not removed? In partial thyroidectomy, the posterior part of the thyroid lobe are left behind to avoid removal of the parathyroid gland, which otherwise may be result in tetany. So this is the location of the 4 parathyroid gland. Why thyroid gland is removed along with its true capsule? In case of the thyroid gland, the venous plexus is located deep to the true capsule. This is the true capsule, this is the false or pretracheal fascia. So deep to the true capsule, this is the location of the venous plexus. Therefore, to avoid hemorrhage during thyroidectomy, thyroid gland is removed together with the true capsule. Whereas in case of the posterior gland, the venous plexus is located between the true and false capsule here. So, during surgical removal of the prostate gland is removed, leaving behind both the capsule. Now, thyroidectomy skin incision. Thyroidectomy is carried out through a transverse collar incision 2 finger breadth above the suprasternal notch. This is the suprasternal notch. So, a horizontal incision 2 finger above the suprasternal notch. This lies in the line of natural skin folds of the neck. Thyroidectomy steps of dissection. Skin flap are reflected along with the platysma and investing layer of deep fascia open longitudinally between step muscle between the anterior jugular vein. This is anterior jugular vein and these are the step muscle. This is sternohyoid, this is sternothyroid, this is sternocleidomastoid muscle. If more room is required in case of large goiter, the step muscles are divided in the upper part of the step muscle usually cut to avoid the cut ansa hypoglossy nerves, to avoid injury of the ansa hypoglossy nerve, which is situated in the lower part of the step muscles. If pretracheal fascia is divided to expose the thyroid gland, the dissection is very difficult and bloody procedure because below the true capsule the venous plexus are situated. Ectopic thyroid tissue and thyroglossal cyst and fistula. This line show the descent of the thyroid gland. Thyroid gland develop here from the foramen cecum, which is situated at the junction of the anterior 2/3 and posterior 1/3 of the tongue, and normally thyroid gland descend in this pathway and reach its final location. So this descent line showing the possible site of ectopic thyroid tissue and thyroglossal cyst and also the course of a thyroglossal fistula. And the arrow shows the further descent of thyroid which may take place rectosternally into the superior mediastinum. Why benign enlargement crumbles trachea and esophagus, but malignant tumor of the thyroid gland cause severe bleeding? The benign enlargement of the thyroid may compress or displace its closest relation. The trachea and esophagus may be narrowed, with the resulting difficulty in breathing and swallowing, and the carotid may be displaced posteriorly. And the benign enlargement of the thyroid gland is enlarged posteriorly because the anterior part of the pretracheal fascia is thicker than the posterior part. So, any enlargement is grow posteriorly and compress nearby structure. In malignant tumor of the thyroid gland, enlargement is not occur, it's erode the nearby blood vessel and severe hemorrhage is occur. Why hoarseness of the voice and Horner syndromes are developed in malignant tumor of the thyroid gland? This is the posterior surface of the lobe of the thyroid gland. Here, this is the relation of the recurrent laryngeal nerve, and this is the location of the sympathetic ganglia. When these two structures involved causes hoarseness of the voice and Horner syndrome. So this is all about clinical anatomy of the thyroid gland. If you like this video, please share this video and please like this video and subscribe my channel, and who already subscribed my channel, thank you very much.